high time we join the race to make the world to a better place. Now, it's the time to focus on how physiotherapy proves with the latest technology and unlock many physical mysteries. So focusing upon the same, our next scientific session is about India's pride hates MMT versus modified Oxford MMT for pelvic floor muscle assessment, transvaginal, transrectal. And to present on this topic, today we have a dynamic speaker with us, Dr. Dhara Shah. Dr. Dhara Shah, Chief Clinical Instructor, WOW, IIPRE Ahmedabad. She is HOD of Pelvic Floor Rehab Clinic, IIPRE, Pelvic Floor Rehab Clinic. She is Clinical Instructor of WOW and Women Health Rehabilitation Specialist. She is a gold medalist and PhD scholar in physical therapy along with the pelvic floor women's health. I welcome Dr. Dhara Shah.
Thank you very much for a warm welcome, all of you. So my speech is not going to be any, my speech is not going to be on any a broad topic. I'm going to give a very specific speech, and that's on hates MMT. So a warm welcome to all the delegates, my friends and colleagues. Yes, one earth, one family, as well as the theme for yesterday and today, which was physiotherapy to physiopathy. I think the topic will serve its purpose when we tell it from physiotherapy to physiopathy. So we are not just training hates MMT and all other intellectual properties of hate. This I saw is not just been trained or accepted by physiotherapists, but it's really been appreciated across 14 different countries, across various medical professionals like urologists, urogynecologists, sexologists, colorectal surgeons, as well as other people who are working in the field of pelvic floor rehab. So yesterday when Ali Rani sir, Ejaz sir, as well as everyone was talking about prevention, you know, if you can prevent something, you don't have to work upon the cure. So with that, we have Sir has developed multiple innovative properties and which are being accepted as well as recognized by even urologists through the book Hates MMT, which is Amazon's bestseller #1 in urology. And before I go further to my topic, I would really like all of you to please view this video because we don't deserve this. Whatever I'm going to show in this video, we actually don't deserve this. So it's just a 30 seconds video if you can have a look at it.
Squeeze, squeeze, squeeze.
This is a case of prolapse. It's a grade 2 cystocele diagnosed by a gynecologist. She's a 52-year-old female delivered through cesarean section.
Okay.
Now when we talk that prolapse in cesareans, that's something gynacs or urogynacs won't accept because they feel that prolapse can only happen with vaginal deliveries, right? But prolapse can also happen with cesarean sections. It can also happen even if the female has not delivered. Delivery is not an empirical to prolapse. So I'll just quickly I'll just once again share this video. You might find it quite offensive for the first time to look at it, but please view it that when the female is coughing, when she's trying to cough, when the vulva is there, her anterior vaginal wall is prolapsing out, right? And do we deserve this? Do we become mothers to get prolapse? No, we don't become mothers to get prolapse, right? We can prevent this dysfunctions. I can see that there is a lot of chaos going on. Just for 15 minutes, if you give of your time, so that you can prevent such dysfunctions. I can still remember a meeting which Sir conducted with the intellectual property lawyers, the engineers, as well as the graphic designers when he was developing and innovating the concept of pelvic floor and different patented technologies. There were around 9 engineers sitting there, and Sir was discussing what is pelvic floor, what is prolapse, what is vaginismus. And two of the engineers were making fun of it because they are non-medicos. They don't understand the importance. When we talk about perineum, when we talk about vagina, we can't give it the respect it deserves, right, at the first time. So the same happened there. Two of them, they started laughing, which made everyone else uncomfortable, including me. Sir noticed it, and he just said that, let's take a break of 5 minutes and let's rejoin again. And after 5 minutes, sir said that, okay, let's all of us do an exercise. I want you also to do with me. Can you just close your eyes for 5 seconds? Close your eyes. Visualize your mother, your sister, yourself, your wife. And now think the organ or the cystocele or the rectocele hanging down your vagina. Would you like that for your mothers? Would you like that for your own? No. If no, then why are you making fun of it? Now, yes, you can definitely laugh if you want. And those two engineers, they came and they said that we are really sorry for disrespecting the most dignified part of a female. That's the perineum, that's the pelvic floor. And it does not stop here. It does not stop here. This was the one aspect. The other aspect, which is vaginismus, which is dyspareunia. Many of us, when we talk about pelvic floor, will limit ourselves to urine leakage, will limit ourselves to pelvic organ prolapse. But there is way more than that, right? When, like in the recent, the session before me, they said that it is physiotherapy and medical is learning, unlearning, learning, unlearning. It's definitely right. Why? Because as you grow, as the medicine is advancing, as the faculty is advancing, there are a lot of things which are really untreated or under the rug when it comes to pelvic floor. This is a case which I want to discuss is of vaginismus. How many of you know what is vaginismus? Can you just raise your hands? How many of you know vaginismus? Great. Vaginismus is a condition where the vagina goes into unwanted sudden contraction, does not allowing even the penetration of a finger. Forget about a sexual penetration. One night, Hetzer got the call from the then National President of National Psychiatric Association. He referred a case which was of 9 years unconsummated marriage. When I say unconsummated, that means there wasn't a physical activity between the husband and wife for 9 years. And he gave a call to sir saying that you are the last hope if we can do something in this case. When sir attended the call saying that I don't do clinical practice, but I'll make my team take care of it. The patient was referred. She was completely disturbed. She was completely destroyed physically, mentally, emotionally, and even spiritually. Because in a continent like India, to have a 9 years of unconsummated marriage is not something people looks up to, right? And she was treated within 16 sessions. She achieved her first sexual penetration. She is having a healthy baby, but that's not important. What is important is the line which she said. She said one day after the session, she cried. I thought she would be happy because she's recovered. Instead, she cried. When I asked the reason of cry, she said that if I knew this, that my treatment is so simple, I might not have wasted the 9 years of my life. So for us, it is just a case, but for the patient, it is her whole life, right? And these things cannot be solved by modified Oxfords. You cannot assess or you cannot check the relaxation of the pelvic floor muscles by doing a modified Oxford MMT. That's the biggest limitation. Even the urogynecologists, the whole field of obstetric and urology, of gynec and obstetrics, they are following modified Oxford. But when we give it a deeper thought, if I ask you that if you get a patient with acute trapezius spasm, will you assess the strength of the trapezius or will you first plan to manage the pain? Natural course, you would first plan to manage the pain, right? But what we do with pelvic floor, If you are getting a patient with vaginismus who is unable to even insert a finger inside, how would you check the strength of the muscles? So the first and the foremost thing is to check the relaxation of the muscles. And with this concept, Hayes sir, he developed Hayes MMT, which solves the purpose of contraction as well as relaxation. You can assess the strength as well as the relaxation of the pelvic floor muscles. The grades are from 0, -1, -2, -3, 1, 2, and 3. 0 being the normal baseline tone, -1 means inability to penetrate. Pelvic floor is a very beautiful subject and it's deep like an ocean. Okay, it's not just a side muscle, it's a layer of muscle, right? I'm not going in technical details because I can speak for one whole day, but that's not permitted. So, if you are assessing the pelvic floor muscles, if the female is not even allowing you to touch, to penetrate, that is a -1 grade, that is inability to penetrate. That is a case of vaginismus, okay? If she allows the penetration, but that's painful, that's a symptomatic penetration, that is -2, which means symptomatic penetration. That symptom can be of pain, it can be of dysfunction, it can be of tightness. Then is -3, that is complete relaxation, okay? If you are at a grade of -3, that means your PFM are able to completely relax, means you will be able to have proper urination, defecation, sexual penetration, childbirth, right? And grade 1 is mild contraction, grade 2 is a complete circumferential grip, and grade 3 is a strong upwards and inwards pull. So the baseline is the scale which is being developed is developed in a way that it gives you a specification. It's not subjective, which is mild, moderate, fair, or weak. It's specific. If you feel the grip, it is 2. If you feel an upwards inwards pull, it is 3. If there is a mild grip, it's 1. It's a mild flicker, it's 1. So that is the subjectivity, or that is the objectivity of the grade. And more particularly, it is measuring both the contraction as well as the relaxation. When you particularly speak about any muscle, you need to have both in place. You need your trapezius to work only when it has to work, not to compensate for other muscles. The same for pelvic floor. You need to let the relaxation to allow the process of urination, defecation, and you should have a proper contraction in order to maintain the core stability, the back stability, and lot more. So this is the grade, and we have done a study for checking the inter-rated, intra-rated reliability, which I'm very proud to announce has come out to be really wonderful. We have given it for publication. It is under review. Once published, I will share the links with whoever they want. One simple request to all sitting here over here is, as we are heading towards from therapy to pathy, I request all the females sitting here as well as all the males sitting here to understand and teach yourself, your mothers, your daughters, or any women who is present in your life to just make sure to assess her pelvic floor at least once a month so that they can prevent themselves from becoming a problem. Okay, we are spreading awareness related to breast examination. We say that it should be done from 15 years onwards. But then why not pelvic floor examination when it can be done upon her own? We forget about the reliability when it is done upon her own. But at least she can know that which way she is heading ahead. I would like to because I'm running short of time, I would really like to thank a few people. First is Dr. Ali Irani sir, on behalf of Hayes Desai sir, because sir has contributed something very significantly in Hayes sir's life before 23 years. That is a long story again, will share it some other time. But a special thanks to sir, as well as to our dearest Yagna Shukla ma'am, for being the first academic expert to cherish the merits of Hayes MMT. And yes, we also have presented the paper on Hayes MMT as an outcome measure in an ICS conference, Melbourne. A special thanks to the IAP and IAPWC, Dr. Sanjeev Jha sir, Dr. Ruchi Vaishnav ma'am, as well as one and all who is working to make this event a success. And I feel it is already a success because we are now becoming ready to not work for cure, but to come to the prevention. We are taking one further step that is towards the prevention. So thank you all for being here. And yes, I'm really very grateful to get this platform. I'm very thankful to Hate sir for believing in me, for giving this platform where I can come and speak on pelvic floor, as well as to all of you for listening to me so patiently. I would also like to call upon Dr. Michael Landry just to give a few words, if he wish, on what is his thought of pelvic floor. Can I just have you please for a few seconds? Yep, thank you. Since he is the world president, and when we talk about pelvic floor, we need to have it more on from the world president. Thank you.
Thanks. Well, let me just congratulate Deepti. I mean, that was a really wonderful presentation, specific. And thanks to everybody for being quiet so we could hear. So nice job over there. The point about pelvic floor, though, is not just a small, isolated event in one particular part of the world, but everywhere. I so happen to have a fair amount of experience in places where torture is quite frequent, quite common. And having a scale that it sounds to me is very functional as opposed to and multidimensional, I think advances us into the future. So I'd just like to say congratulations on all that. I look forward to reading that paper. The ICC, the interclass coordinates, are quite tight, so that's pretty impressive. So I'll look forward to that, but I would like to say this is so important for us as physiotherapists around the world. I'm still exploring the idea of physiopathy because I'm not quite sure what that means yet, but physiotherapists around the world need to know this. So I congratulate you, and I look forward to the conversation up on the stage. So thank you so much.
Yep. Thank you, the chairs, for listening patiently. I really appreciate that. That's all from my side. Thanks a lot.
Hello. Yeah, congratulations, Dr. Dhara, for taking up this topic and explaining it so well. When you were speaking, I just remembered women in India. They have been taken this topic as not to be discussed. And imagine our grandmothers or their ancestors also, who have had to carry pregnancies after pregnancies and in Indian conditions, but they have never spoke about it. That is why maybe we are a little skeptical about not discussing. But now the days have changed, and we really want. And for myself, because I work with children and young adult girls who are into disability, where urine incontinence is a very, very common, I am using some of the techniques which I know, but I would definitely like to be in touch with you for the exact way of prescription it should be. Thank you so much.
Thank you, Dr. Dhara, for this informative talk. I just wanted to know about the role of biofeedback therapy for transvaginal and transrectal contractions.
Yes. So when we talk about biofeedback, it do play a very significant role, but it would also, and there are multiple different options which are available for biofeedback. You can use a periometer, you can use an EMG, you can use a surface EMG as well. So it do play a significant role, but what is the most important thing is assessment and examination. So like in yesterday's topic, one person mentioned about MCELA. It's a wonderful innovation, but just because it is urine incontinence and you make them sit and you make them do exercises does not solve your purpose to be a physiotherapist. When you are a physiotherapist, when you are a pelvic floor rehab specialist, the first and the most important thing is examination. If and unless and until you do a thorough and a detailed examination, you cannot come to the conclusion that which biofeedback would work and how that would work.
But does it really help to prevent cystocele and retrocele?
Depends what grade it is. It is whether a grade 1 or more than a grade 1. So technically, if it is more than grade 2, you cannot prevent its progress. You have to manage it. You can prevent it when it's in grade 1. Once it is a ligamental laxity, when there is a complete torsional force coming on the ligament, you might need external supports like passeries, the intravaginal devices, or in future, in long term, you can even need a reconstructive surgery. But again, post-reconstructive surgery, in order to maintain the strength of the muscles with which the mesh is being attached, you need a pelvic floor rehab. So it's similarly like you doing a TKR without a proper knee rehab. So you need to do a PFM rehab, even if you do go for a surgery or otherwise.
Thank you so much.
Thank you.
Now, I just want to know how does PCOS or PCOD is going to affect the MMT, because if the female, we are getting regular patients of PCOD and PCOS, so have you actually excluded them in your study, or if they have a significant effect on the MMT, yes or no?
Thank you very much for your question, sir. So yes, PCOD, PCOS do have a significant role on pelvic floor. There are mixed articles. Some of them, they are showing that there can be a preventive role, but again, there are certain articles which are showing that PCOS or PCOD can have a dysfunctional effect on pelvic floor. In our study, we haven't excluded anyone. We have included everyone, and we have categorized them depending upon the pelvic floor dysfunction, because my study is to check the reliability of Haig's MMT. So whether this scale is reliable for all the categories of pelvic floor dysfunction. It can be hypertonus, it can be hypotonus, it can be incoordinated, or it can be a normal function. So the females with PCOS or PCOD who had a presentation of hypotonus, we categorize them into group A. Who had a presentation of hypertonus, we categorized them into group B, and the rest were normals. So we didn't exclude them. Yes, we excluded the one which are normal, have exclusions like infections, traumas, tumors, and more than grade 3 cystocele, but rest we included all.
Ma'am, thanks for the answer. Just I want to know, maybe this is not relevant or you have not taken, but the females who were actually doing the studies, how much have you checked that stress has going to affected them, or stress has affected the MMT for that? Because nowadays stress, I just want to know what is the effect of stress on a female vaginal MMT, if you got any patient like that.
Again, it is a very big topic.
I just want to know, maybe it was not included in your study, but
yes,
you
it wasn't included.
You came across this kind of a female who got stress and got any kind of a decrease in MMT?
Yes, so we haven't excluded or we haven't seen the significance of stress and strength of pelvic floor, but the researchers says that pelvic floor dysfunction can happen because of stress, because of lifestyle, and even because of lack of exercising the pelvic floor muscles, along with the other aspects like pregnancy, childbirth, which are all common. So yeah, we haven't seen the effect separately, but we may include it in our future trials where we'll see that how much significantly the stress is affecting.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Dhara. Now I request our chairpersons to felicitate Dr. Dhara Shah. रुक जाओ। अरे Dr. Dhara Shah.